Hi all, I welcome you to this discussion on Fournier gangrene. Fournier gangrene is a rare condition, but it is a surgical emergency. It is a life-threatening condition. It is a very important condition all surgical residents and surgeons should know and should be able to diagnose and manage. So, Fournier gangrene is a necrotizing fasciitis of male genitalia. Other names for Fournier gangrene include idiopathic gangrene of scrotum, streptococcal scrotal gangrene, perineal or scrotal phlegmon, or spontaneous fulminant gangrene of scrotum. It was famously described by Jean Alfred Fournier and hence the name Fournier's gangrene. It's an abrupt onset fulminant gangrene of the scrotum and male external genitalia. Usually it is considered idiopathic, but in many cases sources have been identified which we will discuss subsequently. It can affect the external genitalia, perineum and the perianal region. Usually Fournier's gangrene is polymicrobial, which is an important question. Now let's discuss about etiology of Fournier's gangrene. In more than 58% cases of Fournier's gangrene, the cause is not identified. It can be a result of minor trauma to the perineal region or minor urological procedures like urethral dilatation can also lead to Fournier's gangrene in people who are at risk of developing Fournier's gangrene, which we will discuss. The infection can arise from the skin, it can arise from the urethra, or it can arise from the rectal region. The rectal sources include perineal abscess, fistula. The urethral sources include strictures and extravasation. The main predisposing factors for Fournier's gangrenes is diabetes mellitus, local trauma, paraphimosis, periurethral urine extravasation, perirectal or perianal infections, surgeries like circumcision or urethral instrumentation, and obesity and chronic alcoholism. Some degree of immunosuppression is usually present in patients who develop Fournier's gangrene. Discussing about microbiology of Fournier's gangrene, as already described, it is polymicrobial infection. There is a synergism between aerobic and anaerobic organism, which is classically described as Fournier's gangrene or necrotizing fasciitis. Usually the organisms are facultative organisms like E. coli, Klebsiella, Enterococci plus anaerobes like bacterioids, Fucibacterium, Clostridium or microaerophilic streptococci. Discussing about pathophysiology of Fournier's gangrene. Usually patient will have some risk factor which I have already described and some portal of entry of organism, either perineal source or urethral source or skin source, and patient will subsequently develop cellulitis. Now this is the stage where clinicians should diagnose the Fournier's gangrene early and try to manage it aggressively so that the progression can be halted. The scrotum will become swollen, it will become erythematous, it will become tender as the infection begins to involve the deep fascia. As the swelling increases, it will develop crepitus, which is a classical finding seen in Fournier's gangrene. It is due to subcutaneous gas. As the condition progresses, patient will develop gangrene, which is initially focal and later becomes extensive. The cause of this gangrene is due to obliterative arteritis of arterioles of scrota, which is an important point to remember. As the condition progresses, it may involve the abdominal wall, which is called Melanese synergistic gangrene. Patient becomes septic, gram-negative sepsis usually, which will lead to rapid progression of organ failure and death. The clinical features of Fournier's gangrene: patient may have a prodromal period of 2 to 7 days, having fever, lethargy and other non-specific symptoms. Patient will subsequently develop intense pain in the perianal genital region associated with edema, swelling of the scrotum. The pain is classically described as pain out of proportion to clinical findings. Patient may subsequently develop pruritus and the swelling can progressively increase, erythema can increase Dusky appearance of the scrotum can develop, ulcerations can develop, crepitus is present, and subsequently gangrene develops. Now this gangrene is not seen initially, it is seen later, even though it is a rapidly progressive condition. So early diagnosis is very important. The purulent discharge also is seen. In necrotizing fasciitis, purulent discharge is described as dishwater pus. Now important point regarding pain is, initially the condition is painful. As the gangrene sets in, the nerves are destroyed and it becomes painless. That is, pain reduces. Specific genitourinary symptoms in Fournier's gangrene include dysuria, urethral discharge and obstructed voiding. In case of sepsis, patient can have hypotension, altered mental status, tachycardia, tachypnea and hyperthermia, hypothermia. Fournier's gangrene is a clinical diagnosis, but certain lab parameters are deranged. Patient may have anemia, raised serum creatinine, hyponatremia and hypocalcemia. In some cases, subcutaneous R may be demonstrated in the X-ray. Scrotal USG can render similar findings. When the diagnosis is in doubt or early diagnosis needs to be established, biopsy with the aid of frozen section can be done, which will demonstrate necrosis. And frozen section usually should be done within 21 hours after initiation of the condition. Now let's discuss about management of Fournier's gangrene. As already described, Fournier's gangrene is a surgical emergency. Patient should be resuscitated with IV fluids and broad spectrum antibiotics, usually beta-lactam with beta-lactamase inhibitor plus metronidazole or clindamycin. I have to reiterate that prompt diagnosis is critical and early diagnosis and treatment correlates with survival of the patient. Once resuscitation is started, antibiotic is given. Patient should be taken for debridement immediately. In this case, antibiotic is not a substitute for debridement. So there are some principles of debridement which I have tried to summarize in as 4 E's. The debridement should be early, it should be extensive, it should excise all the necrotic fat and fascia so that you reach the normal tissue, and you expose in the sense leave open, do not cause it. Usually the degree of necrosis inside is more than what we see outside. Usually Buck's fascia and tunica vaginalis is preserved, as it is not usually involved. Once this debridement is done, patient is returned to ICU for resuscitation and may require a second debridement 24 hours, 48 hours later, and in some cases they may require third or fourth debridement also. Now, is orchidectomy required in this condition? Usually the supply of testis is from a different source, that is the testicular artery. So usually orchidectomy is not required because testis is not involved. Some series describe 21% cases which require orchidectomy. Now in case of severe urethral trauma, extravasation of urine, urinary diversion in form of SPC is required. Severe colonic or rectal perforation, severe perianal sepsis, severe sphincter disturbances, fecal diversion in form of colostomy is required. VAC dressing have given promising results. Hyperbaric oxygen therapy has also given promising results in reducing hospital stay, increasing wound healing and reducing spread of gangrene. Despite everything, the mortality rate is between 7 to 75%. Bailey and Lowe describes as 50%, some books describe as 20%. Now let's discuss some common questions. What is the blood supply of scrotum? The testis, as you know, is supplied by the testicular artery. Blood supply of scrotum is from external pudendal branches from the femoral and scrotal branches from the internal pudendal artery. Regarding facial layers of scrotum, dartos muscles is important. The Gollis fascia, which is a modification of membranous or continuation of membranous layer of superficial fascia, and 3 fascias subsequently, which is external spermatic, cremasteric and internal spermatic fascia, which is derived from 3 layers of abdominal wall respectively. Now, in case of urogenital and anogenital source of Fournier's gangrene, in case of urogenital source, because of the attachment of the Gollis fascia to the perineal membrane, this is the limit of spread. The perineal region is not involved. In anogenital source, perineal region is involved. Now, laboratory indicator for necrotizing fasciitis score, Lyrinex score, more than or equal to 6 is predictive of necrotizing fasciitis. Components include CRP, leukocyte count, hemoglobin, sodium, creatine, and glucose. Now, what are the other options for fecal diversion in Fournier's gangrene or necrotizing fasciitis? You can use a fecal management system, fecal tube, and it can potentially avoid colostomy if it is used properly and functioning properly. Thank you so much.